First, we have Andres Jimenez Gomez. He's our first speaker, and he's a doctor. He's a developmental neurologist, advancing lifelong care for individuals with developmental and epileptic encephalopathies. So that's the big DEE word we were talking about yesterday, at Baylor College of Medicine and Texas Children's Hospital, with a focus on transition to adulthood, as well as research in DEEs and other neurodevelopmental disabilities. So I'm going to have him speak. Sorry. And I'm going to read Audrey's too, so you don't have to have me come back up here. Audrey will be following. Hang on. Let me find her bio. Oh, here she is. Okay. Audrey serves as the Director of Patient and Family Advocacy for the Pediatric Epilepsy Surgery Alliance. She draws on both lived experience and formal training to support families of children with medication-resistant epilepsy. She helps them access critical medical, educational, and community services throughout their journey, from diagnosis to adulthood transition. So she's going to speak a little bit more about her background. I'm just thrilled to have you both here. So thank you. Yeah.
Usually a little jittery, so I have to stand around and move and wiggle a little bit. Thank you for the invitation once again. I'm Andres Jimenez. I did neurodevelopmental disabilities in Houston, worked in Florida, came back to Houston. Most of you have heard the story already. And I love the opportunity to talk about transition to adult care because even though I was doing a lot of it in Florida, it is in Texas that I've managed to fit a role in both an adult and a pediatric hospital. So I've been learning from you more than being able to convey a lot of things. And that's, I guess, the most important aspect is that I don't really have any disclosures, or I didn't have any when I put this together. But the more I've been talking to the families over the past couple of days, I realized that there's a couple of disclosures. One is that you might learn less from me than I've learned from you guys over the past few days. And that's just the truth of being in the rare disease space, where you guys know the situation day to day much more than we do. And also, you've heard a lot of models of care and whatnot. I'm not here to preach a model of care. I'm not here to tell you this is the way to do things, because realistically, nobody knows how to do things. There's no perfect. And that is in part that we don't really have the information to say what is perfect, but we also don't have let's say, the clarity about different communities, right? It's very different to transition in India than it is to transition in my home country of Colombia, than it is to transition even within, in Texas and Pennsylvania and Massachusetts and whatnot. And I'm certainly not here neither to tout my own institution's experience, nor to teach my colleagues, how you should be doing things. But I'm here to give you guys a few pointers, because transition is inevitable, right? It's more understanding why it is important. When I think of, families like yours, when I have a chance to speak to families and work with communities in the rare disease space, a lot of folks have finally, the dust has settled and you have gathered a diagnosis, and now, all pieces are coming together. And it's hard sometimes to foresee that you're not under this cloud that is static, but that things are going to advance and change over time, and that you have to, again, foresee that change is inevitable. So you have to know why it is so important for you to put those key elements together. I'm going to speak mostly about the medical elements. I know Audrey is going to speak about a lot of what is actually often more important, which is how do we get all the psychosocial aspects together so to support in that transition within the community. And I'm going to talk a little bit about possible areas of improvement and change. And I think that, even though I'm going to talk about them, I've learned a lot more about what I thought I knew just from being here over the past couple of days. So this is typically the trajectory that a lot of families in neurodevelopmental disabilities and developmental and epileptic encephalopathies go through. And the more and more we get early diagnosis, the more and more this proves to be true for many folks. You have a number of symptoms that I like to think of them as those gray clouds that you're trying to get cover from. You have delays, you have seizures, you have behavioral difficulties, you have communication difficulties, you have a number of different things that are all of these troubling, elements of your day-to-day that are coming together, and you're figuring out who is going to help me with all of these once we come to a diagnosis. And lo and behold, you have that beautiful XYZ Children's Hospital umbrella. That's the one that has all the services. It's such a sturdy, nice umbrella that is going to protect you and that is going to keep that rain away. They're going to hold your hand. They're going to do everything for you. But those clouds are going to move, and that umbrella ain't going to last. And those clouds are going to change. Some things are going to get better, some things are going to get worse. And you're going to have an adult provider or providers or clinicians, a number of specialists that are going to try and help you take cover for those same symptoms, but it's not going to be that wonderful, robust children's hospital umbrella. Because in many ways, and this applies mostly in the United States and in Europe and other countries in this kind of high income category, in many ways, that big children's hospital, that big and robust children's hospital is a model that is relatively static. It looks to me more like a gazebo or something like that. It's very strong, it can protect you, but it is in its place. And unfortunately, in many ways and in many communities, that model is only as good as it can move with you and it can allow you that mobility. So it's not perfect. It's wonderful, but it's not perfect. And unfortunately, I don't have perfect for you, but I have reasons why we need to look for the best available that belongs to us as opposed to belonging to that hospital. Because what happens if we move, right? I hear from my colleagues sometimes that, the thing we speak about is, transition is local. Well, it's local, but we do live in the 21st century and there's a lot of mobility. I myself, I'm an expatriate from a different country. I live in a city where I consult and see expats because of the oil and gas business that come in and come out in a matter of 2-3 years, and they move very frequently. So what happens? How do I take those resources with me? I can't move the gazebo. But what if the clinician retires? And unfortunately, we're in a world where a lot of it is moved by personal interests and money and this and that. And I bet a number of you guys have seen one of your specialists, your key specialists. And, I hate to say that probably I was one for some of the families in Florida at some point in time that said, well, you know what? I have a reason to relocate. What if they relocate? What if they retire? I inherit a lot of patients from folks who have been that beacon for my patients for many, many years. And they said, now that I hit 70, I don't want to work anymore, and figure it out. But what if I have to go to the ER? What if I'm on a trip? What if I go to Disney World with my kids and, we have a seizure? How will they understand what is the need for my child with CHD2 or with whichever condition? Or what happens if I get admitted and instead of being admitted to the pediatric hospital that has given me so much protection, I have to be admitted somewhere else where they have to understand the condition, but who is going to convey that need and understanding? So I told you better is the enemy of good. And unfortunately, sometimes we have to focus on whatever is best that could potentially help us guide through that journey. So I'm all about family empowerment. I'm all about allowing the families to learn about that because we know that from diagnosis to adulthood, these rain clouds are going to come with us. And we have to have a time in which we put together that poncho, in come the poncho. So how do I help families put together that protection? I think very pragmatically. There's very many ways in which we've had a lot of aspects of research of what is the best way to transition, what questionnaires do we pose, what information are we quizzing the families on and the patient on, and there's this questionnaire and that questionnaire and whatnot. And I'm a very simple man, and I from speaking to families, from seeing the families as I relocated to Texas and work in the adult hospital and think, okay, well, where are the voids of the things that people keep asking me about? And where are the voids of the situations that families are facing? I think there's 4 main elements that we need to have clarity on. And that's the information that you guys are going to be empowered with for your own mobility and for your own transition. One is the clarification of the diagnosis that I'll delve into it a little bit more. Well, the second one, and this is very important, it's when you're comfortable with the care as it has been provided, sometimes it's hard to reappraise what that care ought to look like as things evolve, right? Sometimes everything, you finally put a balance on everything and you don't want to touch it because it's very fragile. You don't want to move around it. So you want to leave it be and just step away and leave it and let it go and let it go and let it go. But sometimes that reappraisal is important because as you guys have lived and many of you have seen, conditions such as CHD2, they vary over time and the needs vary over time, and the potential, for example, for one medication to be useful or actually detrimental might vary over time as well. We have to have an understanding of where are the abilities of our children. And this is one of those elements that fascinates me about CHD2 because I speak to so many families and and a couple of my patients and whatnot, and they are very different from other developmental encephalopathy patients. They are very bright in many ways. They are capable, they're competent. There's a lot of virtue that we can't just shove under the rug of this is a child with a developmental and epileptic encephalopathy, because these abilities in this agency needs to be recognized as well to the extent possible. And then, of course, again, those socioeconomic aspects that I know Audrey is going to address. And this is how I conceive it. It is in your best interest and in your hands to put together this information, to bring this up at every visit with your clinicians so that you can identify who is going to be my future ideal care team, but also because you are going to carry around this information. You are going to be the first, second, and third agents for your child or family member. So what does that look like in practice? For me, the first and foremost is that clarification of a diagnosis. Now, we wouldn't be here if we all already didn't have fundamentally a clarification of diagnosis. I mean, this is a CHD2 meeting. This is not just a general meeting of epilepsy or something along those lines. But most of you have gone through that struggle of requesting genetic testing and having to go the extra mile. And I've heard several stories where folks have said, well, I asked for it and didn't receive it. Or when I asked for it, they said, but what's the point and what's the matter? And it really matters. It really matters. And you guys are seeing it day to day right now, because knowing a specific condition means knowing what are the guidelines to support an individual with that condition. What is the best way to orient your clinicians, the folks with whom you are going to interact as your children grow, and to let them understand, hey, maybe azidazolamide might be an option that would only be in the back of their mind at some point in time. Or maybe, hey, Tegretol, carbamazepine might not be a good option as a medication, because we know in this condition, even when you see the seizure, when you hear about the seizure, it's a good fit. It's not a good fit genetically speaking. And because it lends for you guys to be in the position that you're in a wonderful support group that is very, very unique and very, very well put together, that allows you to enter research, to discuss the information that we have been discussing over the past couple of days. So it's not necessarily a problem for us today, although it has been a problem for many of you guys, and you guys become the beacons for other families that are in similar situations and that are looking to figure out what is to be discussed. Now, what does the reappraisal of that diagnosis, testing, and management look like? Now, if we have a genetic diagnosis, if we know a child or an individual, a teenager, has a genetic diagnosis that can be like CHD2, where you have behavioral difficulties and whatnot, we need to reappraise. First, have we done the appropriate workup for the epilepsy care? You heard a little bit from the Colorado team about surgical care in epilepsy, which is one of those emerging and ever strengthening areas. And I think that one of the big things that I've encountered as I meet adults with neurodevelopmental disabilities across the board in my practice is they didn't do the workup on time. And the workup becomes administratively far harder when you're in the adult hospital. It becomes simply behaviorally so much harder when you're in the adult hospital. It's so much harder for an EEG tech to understand why my patient is not sitting still when you're putting on leads in their head than it is for the pediatric EEG tech, who is used to having to battle a little bit with, even a 5, 10, 15-year-old. Are we appraising what medications we should be using in consideration of things like behaviors, right? Are we really understanding what is the best medication that can do the most bang for your buck? Is it Depakote, for valproic acid, for example, that could be dealing with some of the behavioral aspects, because we know there's a high burden of psychiatric difficulties in CHD2. Could we be changing and readapting ourselves and reappraising some of those aspects? Are we really acknowledging the depth of behavior care? How much of it depends on communication? Are we really offering the correct services in terms of the medications and their interactions? And one very important aspect, which brings me back to one of the family's questions yesterday, which I thought was absolutely on spot on, was why do we get occupational therapy or physical therapy for my adult patient, right? Is this the right therapy, and what am I doing it for? And that tells you that much of this is about you guys understanding and owning that care and being the agents of your child and your family member, because it's really understanding, well, it's not just about perpetuation, not just about keep going that occupational therapy, but what is my 90-year-old receiving occupational therapy for? Is occupational therapy the right decision? Should we go to a vocational care service where they get, skills training and something different and something that will allow them to earn a salary or allow them to work in a different placement? Are we focusing on social skills, or are we working on functional communication skills? Do I need to help my child with preventing disability with walking or with scoliosis, or are we doing physical therapy just for the sake of doing physical therapy? And that goes hand in hand with that competency and cognitive evaluation. We really need to understand at the time of transfer what level of independence or autonomy is anticipated. And I think that most of you guys, when I speak to parents, especially the more gray haired they are, the more worried they are about what the placement is going to look like the day that they are gone. And that is something that we need to really have discussions on. And you guys need to really have those discussions on. Nobody likes to have those discussions, but they have to have those discussions of, okay, well, where is my cognitive level? That doesn't necessarily mean a child or an individual who has grown with CHD2 from, for example, the data that we saw from the Canada group, that if you are doing many things at a 5th, 6th grade level, you're probably able to understand how you take your medication. You would be able to understand what time you take your medication and so many of those other faculties that are going to be far beyond what you might find in another condition, or if you simply label a condition and just call it, oh, he has a developmental and epileptic encephalopathy, because that's not the first thing that comes to mind. Now, we did also hear yesterday from the Colorado group that you wouldn't have received developmental testing unless it was a 4 or 6 hour or 2 or 4 hour developmental test. And although I agree that that there is importance and value in these very extensive cognitive and developmental tests, I do think that from the practical perspective, and even from the perspective, especially at the time of transition or right at the point of transition, the need for some clinical versus more extended testing might vary. Because, for example, I get a lot of testing that I conduct. It's not a 5-minute questionnaire. I do standardized testing measures that might take me a half hour. I get myself an extra half hour in the clinic just to get a cognitive level and adaptive level so that I can assure that my patient is going to receive or become eligible for services because of that clinical diagnosis of disability. Because you guys know it, you don't receive the services from being CHD2, monoallelic variant, blah, blah, blah. You do receive the services because you have autism or intractable epilepsy or intellectual disability. That is really what, unfortunately, at least in the United States, the government is looking for as the marker of access. And if they are cognitively well, what other hindrances are we anticipating, right? If we have established what cognitive ability, what competency we have, well, have we established what risk we have for other behavioral difficulties, right? I don't like to speak much about autism because autism, I think, has way too many flavors. I like to think about behavior itself. What is the severity of the behavior, and particularly how does that behavior affect your ability to perform in a community? And how is that going to be a hindrance when you go out in the community? And how can we support that? How can we support aspects of attention and executive function? There's, I have at least, one of my patients over time, extremely bright individual, but it was so very hard for this person to come out with the words that they wanted to say to me oftentimes. And, we and this, I hate the word, but we had to play around a little bit with medication to see what would help them be able to produce the knowledge that they already had inside. And then I'm not going to touch too much on the socioeconomic aspects, but it is about understanding that cognitive diagnosis to get you access, that eligibility for the diversity of government services. It's a very different story in Europe. It's a different story, unfortunately, in South America and Latin America and other continents for us. But it is not dissimilar in the sense that you need to start early on in these processes to identify what are those needs. But, I hate to put the onus on you guys, but it really is something that no one is going to do better than you guys for your family member. And that comes down to, if you guys are, I guess some of you guys are old enough to remember that commercial where they talk about don't leave home without it. I think it's American Express or something like that. I can't remember. It is about having that information that you should carry around, because you know more than the clinicians for the most part. You are carrying around that clinical and genetic diagnosis, that information. There's different flavors of these passports or letter of transfer and whatnot, but it's information that we should actually be figuring out how can we make it more practical for you guys to carry it around. Could we have a transition of care app that is something that you carry around and pulls in from the medical records and updates itself, so that you have this information easily shareable, but that you also have contact with those key clinicians, that you guys can reach out to Dr. Nupp, for example, and say, hey, I'm in Louisiana and I need support, and this has been the process of care, and Dr. Nupp, they're not understanding that my child has CHD2 and we shouldn't be doing this or that medication. But also designing that ideal care team. And, interestingly, the pediatric neurology practice has always been the medical home, again, that gazebo practice. But the reality is that we fail to convey that, the primary care provider is just as important. And especially in the adult world, the person who is going to do the day-to-day, vaccines, to anything else is going to be helping us with eligibility for services, with behavioral care, with many other things. You have to have clarity about neurologists and clarity about specialists. And this is all of those bits and pieces of information that you're going to be putting together if you have clarity about what the diagnosis looks like, and you have agency and you have the empowerment to be looking for those, so that your discussions during your clinical visits are not about how are we going to put this transition together, but rather asking, do you think this is the right individual? I read about this other person. Who do you think is the epileptologist that is best dedicated for this? And who do you think would be the best psychiatric person among these three that you have already researched, and that you are a step ahead of us in the static children's hospital? Now, again, I'm not going to tell my institution. I'm going to tell you three models of how we do things, and I think they're all equally imperfect. We have an Angelman syndrome clinic, which may look a lot like the chromosome 15 clinic over here, where we do clinical visits typically yearly. Some folks come from so far away, it's every other year. We do them for research, for multidisciplinary consultation aspect, for delivering that plan of care and supporting your local neurologist and whatnot. And we do the transition within that very same clinic. It's a little bit different than the Rett syndrome, another developmental and epileptic encephalopathy that has made it its mission to have lifelong care. Now, that is a different flavor. And in other developmental and epileptic encephalopathies, we have other subspecialty clinics, but we typically do it under the bigger umbrella of the Bluebird Circle Neurology Clinic, in which we have that continued neurology consultation. If you need to be with the epilepsy group, if you need to consult with the neurodevelopmental disabilities group, if you need to consult with my neurodevelopmental transition clinic, every folk in the overall Bluebird clinic should be applying some of these transition program guidelines. And we are working to make the family be the ones that are holding us accountable for that. But in the end, we all need to figure out that this is not the perfect model, right? Delivering down to an adult transition specialist like myself, who is, parked in another static institution, and another number of service providers that are going to be helpful for my institution, is not going to be something that when I give a talk or when I discuss with families for other conditions in Latin America, for example, which I do very often, they say, well, can I fly and come and see you? And that's not the way it should be. It shouldn't depend on your access to a person like myself. So these are imperfect models. I am more of a proponent of, better is the enemy of good, and you should be the master of that information. So transition will happen, as I mentioned. Whether you like it or not, whether we're ready or not, it's going to happen. So you can guide us. You can be the ones holding us accountable for that transition, and you can tell us what we need to focus on. Because oftentimes, that top-down approach, we're controlling your seizures. We've heard it in several occasions. Maybe we reach sufficient control of seizures. How about we shift focus to what are the behaviors? What are those other difficulties in that transition? The team and the setup are going to look different. I think it's unrealistic to expect that teams such as the one over here, or our team in Texas, or other teams in Boston and Philadelphia are actually going to be able to take care of so many individuals with so many different neurodevelopmental conditions, because it's going to stress the system out, and the quality of care is going to eventually suffer. And we really need to be able to convey this so that it is ominous for the adult side to also accept that that is part of their need. We can't, as much as we love keeping our patients and caring for our patients, it's unrealistic to think that transition is not going to happen. So I think we need to have an early preparation, because one day someone is going to pull that rug under your feet. Don't let that transition, that long-standing process, become transfer of someone just handing you over to the next guy. And there is no perfect way for lifelong care. I can tell you that as little as I've participated in lifelong care, I know that my system is quite imperfect. But when I talk to folks in colleagues of mine in Europe with which we work and collaborate, they say the same thing. There's no perfect system, and even in a completely different medical and healthcare system. So you must learn to plan for what best suits your situation. Thank you, guys. Oh.
Well, that's a hard act to follow. But I'm going to come speak to you today about the parent and advocate perspective rather than more of a clinical perspective, although I thought Dr. Gomez Jimenez did a really beautiful job laying that out for us. And I'm really honored that I was invited to speak today, so thank you for having me. So my part of this session is about looking beyond the healthcare transition to navigating the educational, social, emotional, and employment needs of your children that they may face as they grow into adulthood. I don't have enough time to really cover this topic, so it'll be a very broad overview, and then I have a number of resources that I'll share with you. And as you probably know, transition is not one big step, and also it never really ends. So it doesn't really matter what age your child is. You might be going through transition with them or preparing for transition or accessing services or making changes throughout their lives. For some of our children, they may get a job and have independence, and for others, they may need full-time care. But the goal is that we support them to have a life filled with meaning, joy, and connection. So thinking about what long-term planning is needed to build relationships, supports, and the daily life skills they need to survive. Before we begin, I want to thank UCB for, oh, why is it not advancing? Oh, I'm using the wrong thing. Thank you to UCB. They've supported our transition work over the years, and we're really grateful. So a lot of the resources you'll find online, we have their support to do. All right. So a little bit about me. As Marnie mentioned, I'm the Director of Patient and Family Advocacy for the Pediatric Epilepsy Surgery Alliance. For the past decade, I've supported families navigating drug-resistant epilepsy, not only with surgical decisions, but also the developmental impacts that come with them. Our mission as a caregiver-led and science-driven organization is to help families understand all their treatment options and advocate for earlier referrals when medications fail. But most importantly, and from my role, is we offer clear, accessible tools, not only about understanding surgery, but also recovery, long-term care. We provide practical tools for school reintegration therapies, transition planning, and independent living. Everything we've created is free and online and available to any family who's navigating a neurological disorder or neurodevelopmental disorder. We also run a parent support navigator program, and we run a global pediatric epilepsy surgery registry to better understand the long-term outcomes after pediatric epilepsy surgery. And our focus is not just on seizure control, as many of the speakers have talked about today, but we're really looking at the full journey, because our children will not stay children forever, unfortunately, as much as sometimes we want to save them in glass and preserve those precious young days. That doesn't happen. So, all right, this is my son, Bennett, just so you know a little bit about me as a mom as well. I'm not a CHD2 mom, but he had a stroke before birth, and he developed a type of epilepsy called infantile spasms, which I later found out is called a catastrophic form of epilepsy. He failed many medications, and at age 2.5, he had a hemispherectomy, which was a surgery to remove half of his brain to stop seizures, and it was successful. He has multiple disabilities, so vision, hearing, cognitive, physical, sensory, autism. He's kind of got the whole list. And today he works part-time at a small theater in San Francisco with help from his care team and our state's vocational rehabilitation agency. And that outcome took 10 years of effort, planning, emails, evaluations, trial and error. So like many of you, I'm asking all the time, what happens when I'm not here to make things happen? Who will help him? Who will plan for that? So if you're wondering the same thing, you're not alone. That's what we're going to talk a little bit about today. All right. So in childhood, our children have IEPs, care teams, multidisciplinary pediatric teams who know them well. And Dr. Gomez Jimenez just did a really nice job talking about this. As children, there's a structure in place and there are laws that protect them. But after 18, much of that disappears. And as parents, we become full-time case managers, coordinating medical care, housing, transportation, benefits, services. Most systems don't talk to each other. It's fragmented. It's exhausting. Oh, I'm sorry, I'm on the wrong. Here we go. Well, we'll skip to that and I'll come back to that. And sorry, my slides are off there. I'll finish this and then we'll skip over that slide. And it's not just built for kids like ours. And I think when I was listening to Dr. Gomez Jimenez speak, I was thinking about, yes, we have to be the ones that get that medical summary. Yes, we have to be the ones that know everything about our child. Yes, we have to find the appropriate care. And that's where the burden lies. Sorry. When we, as case managers, we end up taking on everything, and it's exhausting. So let me go back to this slide now and just tell you that, unfortunately, while you spoke beautifully about there's a nuance to our children, and we don't want these blanket words like autism or CHD2 or whatever it is, a word that does not describe our child. The gatekeepers of adult services are often not as nuanced as Dr. Gomez Jimenez is and his colleagues. And so we want to use key terms in adulthood, like neurodevelopmental disorder, like developmental and epileptic encephalopathy, that can help explain the lifelong nature of your child's needs. So if you don't use that language, worst case scenario language, you can be shut out of services that your adult might need. Okay, thank you. I'll do that then. Thank you. Sorry. It's because I was thinking I was sliding it there, not that way. Sorry. So in many cases, an autism diagnosis is the diagnosis that opens the doors to services. And I've spoken to a couple parents about this weekend. Some doctors don't want to give an autism diagnosis to a child that has another disorder or has a brain injury or had surgery because they don't view it as true autism. I would just say find another doctor, because having that diagnosis, sometimes the gatekeeper will only see autism, cerebral palsy, maybe intellectual disability, and otherwise you're not walking in the door to our services. So that's really, really important that you're using that language. We have to describe our children by their most severe needs to get services, because the eligibility services require that. We're not exaggerating. We're just making sure they get what they need. Or we'll skip that slide because I already said that. So this is what people will often call the transition cliff. So school ends, the needed adult services either don't exist or there may be years-long wait lists. School teams often don't think far enough ahead, especially for students with high support needs. So don't expect your school to do this right and to guide you, unfortunately. Pediatric providers may not help the transition to adult care. Often there is very little, if any, meaningful transition planning taking place, despite existing frameworks and best practice recommendations from Child Neurology Foundation, GOT Transition. There are a number of tools. I'm going to share a toolkit with you at the end. It's not happening. So, and sadly, in the adult world, there are providers that will not accept young adults or adults with developmental disabilities or high support needs, that either don't have a changing table in their office, or they don't just have the training or experience with rare pediatric conditions. And so they just won't accept them. And that's really sad. So we have to start now to build a bridge. We don't want to fall off the cliff. So starting early to ask your child's school team, your medical team, and other support services, what will life look like for my young person after these supports end, or if they're already in adulthood, really thinking through the whole day of what they need. Where will they live? Who will help? How do we prepare for a future when we're no longer coordinating anything? We have another speaker coming to talk about some of these issues, so I'm just going to go briefly over some of the key areas that every family needs to think about. So decision-making, at age 18, your child becomes a legal adult, whether they're ready for it or not. And if you don't have legal protections in place, you could be barred from looking at their IEP due to FERPA privacy laws, to going into the emergency room with them if they have a medical issue. So really planning at least a year ahead of their 18th birthday to have some sort of protections in place so that you can continue to make decisions on behalf of your child. Financial planning, which I know our next speakers are going to talk about, but remember that gifts or savings from well-meaning family members, or even an insurance policy or retirement account, could disqualify your child from public benefits that they may need to get support. So we want to use ABLE accounts, special needs trusts, to protect those supports. It's a really broken system, unfortunately. So if your head is spinning and you're thinking it can't possibly be this way, I'm here to tell you, unfortunately, it does work this way. And you have to learn how this system works and then use it, because there are just a lot of barriers. And then healthcare transition, Dr. Gomez Jimenez spoke about this beautifully, but we know that a lot of pediatric doctors will stop seeing our kids at age 21. So if you're not asking now who will care for my child as an adult, and literally the name of the person that you are referring my child to, and can I have not just a transition plan, but a warm handoff? And if they're not going to walk you over and have a meeting one-on-one with that doctor, maybe you have your first adult care appointment before you end the pediatric care. So there's at least some conversation in my chart of what you said in that first appointment. Oh, we didn't think about this, right? So there is somewhat of a handoff. And then that portable medical summary is so important. And I know I'm going to run out of time. So family readiness. So one of the biggest barriers to a transition to adulthood, it isn't the system, it's us. We're not always ready to let go of the pediatric of the child. And so, but the earlier we start to imagine what adulthood might look like, the more peace we have. Even adults that will not live independently deserve to be treated as adults and to have independent goals and thoughts and ideas and planning, right? So we want to really think about thinking about what the holistic care planning. What do they want as an adult? Can we build a plan around their strengths and interests, and thinking about who can help later? What role can siblings or friends play? When I created my son's future care plan, I asked a friend of mine to be part of it. And she said, I'm not really good at finances or decisions. And I said, that's okay. You bring him joy. You can be the joy coordinator. So everyone has something to offer. Think really broadly when you're thinking about supports. You may have heard the phrase, how do you eat an elephant? One bite at a time. That's what transition planning is. You can't start when your young adult is 17 and a half. We have to chip away over time. One binder, one phone call, one conversation, taking a course maybe where you meet once a month with a group of people to write your future care plan. That can be really helpful. It feels daunting, and it is, but starting early and doing a little bit at a time makes it manageable. We worked on a transition to adulthood checklist, or the life stages checklist, with the Rare Epilepsy Network, which really provides a great overview of transition step by step. And we just did a webinar on it with Deep Connections, which I highly recommend because there were some great parent voices there. So that I really recommend taking a look at that. And then the question I'm always asked is, when do I start planning for adulthood? And I would say today, right now. So no matter what age your child is, whether your child is 30 or 3 or 30, it's never too early or too late. I think transition planning should begin the moment you know your child has a disability of any sort or any complex needs, because the diagnosis changes the timeline, and therefore it changes our decisions. And again, we're thinking about what brings your child joy, what support will they need, who are your trusted people. You already know your child better than anyone. You are already an expert in your child. So just start writing things down. Your ideas will become your plan. Don't be afraid. You can do it. So we have some great resources at the Pediatric Epilepsy Surgery Alliance, which in the interest of time, I'm not going to talk about. They're linked here. My slides will be shared, and then we have a resource document. And then my second favorite list of resources are here. The Care Binder is UCB's creation for adults with DEEs, a really great tool. It's a little unwieldy, but I highly recommend going through it, and all of these other resources. And then I think that's it. Hang on. Oh, wait a minute. Yeah, that's it. So I will come back right before our panel this afternoon to talk about psychosocial care and some other issues. This has a QR code that links to my resource document. I have some flyers here and cards if you want to get that. I'm happy to email anything to you. Thank you. Sorry, I had to rush. A little bit of time issue.
Before we go on to the next ones, I just wanted to, ask for questions. Andres, would you like to come back? Does anyone have any questions before we move on to our next one? And I will just say personally, we could spend a whole nother day, multiple days just on all the topics today. So the goal really today was to introduce you to some of the resources that you can, so you have someone to call when you have a question. So please, scan the QR codes and go to the websites, because there's so many more resources.
I just have a question. Is the cognitive competency evaluation that you mentioned the same as the neuropsych evaluation? And how often should we do it?
So that's a very good question. It really is not per se the same thing. There's different ways to skin a cat, so to speak, in what you need to reach some of those clinical diagnoses that Audrey mentioned as well. So, for example, in order to have an evaluation where, if we know a child or a person has an intellectual disability, all you need to prove is that their IQ, so the cognitive aspect, is below a certain cutoff, and that the adaptive, so the day-to-day living skills, are sufficiently impaired. And that's very easy, so to speak, to do with just a couple of things, a couple of measures. In order to diagnose a child with autism, for example, obviously I rely on my own expertise, but I have to document it somehow. And there's very limited scales that I can do during a clinical visit to say, you know what, you score high enough in the childhood autism rating scale. And that's it. That's the score that they're looking for. And I can document it as, you meet the DSM-5, the Diagnostic Statistical Manual criteria for the diagnosis. Now, when I think about neuropsych testing, the depth, the 4-8 hour neuropsych testing has utility in different frameworks. And in the framework of research and understanding, for example, the natural history, because you're looking at so much of a big span. When I do cognitive testing, I do nonverbal and verbal intelligence. So the intelligence that develops from language development and the intelligence that develops from visual perception and fine motor skills. And those are just two numbers, but it doesn't account for working memory and processing speed and other aspects within that memory or that cognitive building. But those may be important aspects when we do natural history studies and want to understand the impact of a medication or changes over time that are a lot more nuanced. Or, for example, for epilepsy surgery, when we want to locate, for example, where is, certain traits of memory parked in the brain, or what aspects of, your cognitive processes are parked in one area of the brain, and how would that be affected, for example, by testing. And there's another framework of testing, which is psychoeducational testing, kind of all under the same umbrella, but the psychoeducational testing helps with the resources that Audrey mentioned, but also within the school setting to understand, hey, how does this disability fit the IDEA in the United States, which is the law for protecting or enforcing the individualized education programs, to know what services you ought to be receiving in school. So they're all different flavors, but the bottom line is you really don't need the full neuropsych. You need the selective targets because of what we are really looking for.
If you go into the course there's two courses I shared, but the Navigating the IEP Process explains the difference between psychoed and neuropsych. I'm not sure if I have something in there about testing nonverbal children, but I will soon if I don't already. But that's if you're looking for an evaluation and you speak to an evaluator and you say, I have a child that has X developmental level or is nonverbal, and I'm looking for as an evaluation to help get adult services, like basically an autism or NDD diagnosis. And they're like, oh, I don't do that. That's not the right evaluator. So I think as parents, when you go to any evaluation, even in the school setting, that's your moment to articulate what it is you're trying to get out of that evaluation. It's not something they give to you. You tell them, I want you to evaluate. You know your kids, but you can't walk into an IEP meeting or a service agency and say, I know what my kid needs here, give them this, right? The evaluation is kind of the gatekeeping system. So the only way to work the system is to have a list of questions when you go in for the evaluator, or have a doc. I go in with a 2-page document about my son's existing diagnoses and disabilities every time he's evaluated. So the evaluator's not starting from a blank slate. And I'll usually have very clear questions for this year. He's 21. So if I was to have him reevaluated now, the questions would look very different than when he was 8, right? So you're coming in with your questions to shape that evaluation to be meaningful for what you need it for at that moment. It's not for them. They don't need it. You need it. So make sure you're getting out of it what you need. Yeah.
We've got a question online asking if the transition of care app that was mentioned, is it specific to Baylor, or is it available to other pediatric centres?
It's hard to hear you. Can you say that again?
The transition of care app, is that just at Baylor?
It's our pipe dream.
It is a dream that we discussed earlier. So we need to come up with something, and we need to come up with something not only for CHE2 but across the board. But it's really about what principles would we fit into something like that. So if, and hopefully it's not an if, but when we figure out how to come up with something like this, it'll be broadly available.
Yeah.
It wouldn't be a Baylor thing.
So there's no transition of care app yet, but I think it's a great idea. What you can do is we have the free online transition course. We have a guide. skim through it. It's a lot of information. It might feel like too much. And then start writing your memo of intent or future plan or whatever you want to call it. You can use the care binder from UCB as a framework. It's about 100 pages long. So again, it feels daunting, but I have I have a Google Doc that's shared with his care team, which is our close family members and a few other people. And I treat it as a living document. Every doctor's appointment, the notes go in there, what he likes, because it changes from year to year, week to week, right? So having a living document of some sort that isn't something that you pull out once a year and dust off. So until there's an app for that, I would say there's other ways to do this. If you don't feel comfortable with Google, Apple has better protections. There's Dropbox. There's different ways to have protected online information, but start writing it. There's not a magic tool, but you know your kid. What do they like? What do they not like? What supports do they need and when? It's, all of that. What brings them joy? Who do they need in their life? That sort of thing. Yeah. Okay.
Marnie?
Oh, we have one more? Sorry. Oh, two more.
Hi, I just had a quick question. When you were talking about the care team, I was really intrigued by the idea of having different people responsible for different things. Is there like a list of things or some suggestions you can make around? I mean, some of it is, finance, transportation, but I love the joy piece and things like that. Do you have like some other thoughts? It makes it feel a little bit more looking at it holistically.
So there's there's a financial planner I really like, who's on the East Coast. It's All Needs Planning, I think is what they're called, a group of women that are all moms of kids with special needs. They talk a lot about micro boards, which I have not used, but a micro board is basically the board of directors for your young person. And I think it's a brilliant idea. I haven't used this myself yet, but and I think the UCB Care Guide probably has some suggestions. Our transition course has some suggestions, but again, it's going to be very unique to your person. Someone might need a personal driver and a personal chef, and someone else might need a nurse who can do suctioning and overnight care. So your care team is going to look as unique as your child, but I would think about everything your child needs from the moment they wake up to the moment they go to sleep every day, including the non-medical, non-educational, non-working, like the other stuff. At the end of the day, which I'll talk about in a minute when we talk about psychosocial care, it's all about connection. And that's true for every human being, regardless of their level of disability. So that to me drives my planning for my son is I can get all the right services in place for him, but if he doesn't feel like he has a connection with other people and belong in a community, he's going to be unhappy, and it's not going to work. So sorry, I don't have a straightforward answer, but it's just like everything in our lives. It's complicated, but we can do this. We can figure it out. So was there one more or are we done? Okay.
So we have an 18-year-old that we're in the process of changing over all of her care to adult doctors. Do you recommend us trying to find care within one hospital, or going to the best place for CHD2 doctors for each different type of treatment?
It's a bit of a complicated question because there's two things about it. I think that folks in the continuum of care of something like CHD2, they benefit from coming to places like Children's of Colorado or going to places like Texas Children's and whatnot to have periodic evaluations where you are getting the most up-to-date information that may not be in the purview of your provider right away, then and there when they're more general and let's say taking care of so many other things. And at the same time, you have to be willing and able to pass along that knowledge and collaborate so that your new providers are also capable of learning and adopting new things. In the adult world, it's also very different when you have a very curious and capable, let's say, neurologist or something like that, or for example, a primary care provider. The care in many ways is much more, let's say, centralized to the one provider as opposed to the one team. So oftentimes, the same person can do a lot of the behavior care, a lot of the neurologic care, a lot of certain, multitude of things. So I think that it's kind of a combination of both. You find the right person and you continue involved with some of the groups so that you get updated information that you can pass along. And I think of us physicians and clinicians in general as lifelong learners as well. Sometimes we don't have the time, but it's more and more common that these folks that have lived in this world where there's not a lot of information, they're willing to take that information from the families if someone has digested it for them as well. So if Dr. Knupp and her team has digested it and they come up to one of my colleagues in epilepsy, they're going to say, yeah, okay, that's interesting. Let me look at that article. Okay, fair enough. Then we will do as recommended.
I'll add one thing. My son's almost 22 and he's aged out of or is aging out of all of his specialty care providers. The primary care specialist is really critical in adulthood, in my opinion. And we were lucky we found a primary care provider who is trained in developmental pediatrics, but is an adult PCP. So she's educating me in ways that I have never been educated. I've also heard some recommendations for family care doctors because they look at more of a holistic lifespan, and you could have the same provider and you can start before age 18 for that primary care if they're willing to take on the specialist. Sometimes it's hard. My son has a shunt and he still doesn't have an adult neurosurgeon, and we're in a major city because no one will take him, because if you looked at his MRI, you'd be scared and run away. So it's hard sometimes, which is why really asking each specialist, who exactly am I going to see? And then you make that phone call. And if they say, no, I'm not taking, then you go back to and you need to start thinking about this before they actually age out. Not that your doctors won't talk to you once you're gone, but it's harder because you might not have access to the same MyChart, or they're not billing for their time anymore. You know, you want to really be having that. And then providers can change. So it's not like you're going to keep any provider forever because they could retire, et cetera, but really starting to ask these questions and find the specific people as early as possible so that you can have a transition rather than just a transfer point in that transition of care for the healthcare. Yeah. Hope that helps. I know we're way over.
That's right. Yeah. Like I said, we could spend a full day on each one of these topics today. So thank you guys for being here. I really appreciate it. No worries. Yeah. And again, the whole point of bringing all these people here is to start the conversations, all of y'all thinking, and giving you the resources that you can take home and start utilizing. And then you have people to call when you have questions.